Okay, so let's do another case from Radiopedia, not this one. We'll do a very random case. Let's see what we've got here. So let's start. So this is a head CT. We start with non-costrous axial slices, and we just, when we look at it, we surely see this deviation of the uh, central line. So what is the cause of it? Do we see any subdural hematoma or something? We probably see something right over here. Probably has some kind of a, I don't know, a space of divine lesion or something. Let's see if we will get some MRI. It doesn't seem that he has. Maybe he has some isodens bleeding that are maybe here. Maybe there is subtle isodens. I think there is some space occupying lesion right over here or something. There is deviation of the midline, of course. So he is probably not in a very good shape, this patient. But I'm not sure. I don't look at the symptoms in the presentation or the question asked from the radiologist. But let's start without getting any info because it's better. So I think maybe there is some subdural right over here. I think it's maybe subdural. There is some confusion, maybe some space occupying lesion. I wish we'll get some more imaging, like of course an MRI. We've got some space occupying lesion right over here. It's in the area around the hypothalamus and pituitary, something like craniopharyngioma maybe here, some pituitary adenoma, some Raschke cleft cyst. Those are the differential for me for this place that I can think of right now. Maybe there is, I don't know, maybe there is, this is in the sagittal sinus, so maybe there is some sagittal venous thrombosis or something, because there is some hyperdense in the area of the sagittal sinus. Okay, so I think they will get an MRI. Yes, and they did. Okay, there is something over here, of course. And what we've got here? Some subdural, maybe? What about the lesion? Okay, on flare, we still see this hyper intense lesion. So it's, of course, not a CSF or something because it's hyper intense. So it's, of course, not CSF or something. I don't see any lesion, I must say. I don't see any space occupying lesions, so no space. What is going on over here? What is this thing? What I see right over? What is it? Corpus callosum and things like this. What's going on here? Okay, so there is, of course, some hyperintense material right over here, but it's hyperintense in all sequences. And they didn't give contrast, so they didn't even think about a space occupying lesion. What, just subdural with deviation of the midline? We need to see if there is some herniation. The Mickey Mouse looks quite a little bit deviated, but quite fine. This, I don't know, subdural, what is it? This is subdural hematoma that is, I don't know, isodense. So it's, I don't know, what is isodense? It's subchronic, subacute, chronic. Maybe some medullary veins of an old patient. I don't see too much atrophy, but this brain is probably compressed, so it's quite hard to say. But I don't think there is too much atrophy on this brain. So why would this patient would have some? And okay, so let's look why this patient came. So it's a female, 30 years old, headache, then impaired consciousness in the patient with valve replacement, receiving anticoagulants. So this patient receives anticoagulants, so it's higher risk for bleeding. Probably bleeding, but it's not from an aneurysm or something like this, because aneurysm would cause some subarachnoid hemorrhage. And here we see something that looks like subdural and not epidural hemorrhage if this is bleeding, but this is probably bleeding because it's 30 years old with headache and anticoagulation. So it's probably a subdural hematoma, I think. This is maybe the most likely diagnosis, I think. And there is no SOL, space occupying lesion, that I thought. So we are talking about subdural, yeah? I don't see any other thing to think about, any other differential to think about, not too much, of course. And there is no MRV, so I think what I saw was part of this subdural. Yes, this is what I saw. It's probably part of the subdural. Okay, subacute subdural hematoma. Yeah, it was a subdural and it was subacute. This is the reason why on CT we saw a isodense lesion with deviation of the midline, which said that this is quite terrible. Probably this patient got a burr hole something with reversing of the anticoagulation. So subdural hematoma is the presence of blood between the dura and the arachnoid. It's under this, the dura. We have pia, arachnoid, and dura. Eh, this was reversed. If we're talking from the outside, so it's dura, arachnoid, and pia. So it's subdura, between the dura and arachnoid matter of the meninges, so it is named, termed extraaxial. In the subacute stage, subdural hematoma appears isodent to surrounding brain parenchyma, as we said on CT, they mean. This makes it harder to be differentiated from brain parenchyma. Note its indirect effect in the form of mass effect described above. Of course, there is a mass effect, there is a midline shift. This patient probably is going to herniate. Maybe she did, but I didn't see quite clear. MRI offers more characteristics of aging hematoma. It appears bright on T1 and on T2 owing to extracellular metahemoglobin of late subacute hematoma. Okay, so we had a case of subdural hematoma that I initially thought that I see some SOL, but probably this SOL is just a brain cortex that is deviated and compressed. So this little isodense, maybe a little bit hyperdense area was indeed subdural, but I saw only this area I missed. And on MRI, you see quite clearly the subdural hematoma. You see that it's subdural and not an epidural and not subarachnoid, because epidural would look like this, and there is a thing with sutures that epidural should not cross sutures, and there is some suture right over here, right? I think there is something, and this subdural go throughout it. Epidural wouldn't do it. Okay, anyway, this is like half of a moon. It's the classic look of a subdural hematoma with a midline shift. Probably she's going to herniate if she didn't do it already. I think she will probably need a burr hole and reversing of the anticoagulation. That's what I think. Of course, I'm not a neurosurgeon, and probably a neurosurgeon will know much better than me, even though we just walk throughout the case from Radiopedia. Thank you very much. This was it. This was a case, very perplexing case of subdura. And the important thing to take away is that subacute subdural hematoma, or subacute subarachnoid hematoma, but any hematoma, the subacute may be isodense to the brain parenchyma and therefore be easily missed on CT. Thank you very much. Thanks for Wikipedia. If there are any mistakes or corrections, please tell me. And that is it.